part of Public Health Court is focused specifically on residents in NYCHA, in the neighborhoods within Brooklyn, Queens, Manhattan, and the Bronx, that have some of the highest rates of chronic disease. What we've seen in terms of outcomes in the history of that program, again focused in NYCHA, is that there's been a significant improvement in self-rated health for the participants in that program, which is really important, and significant improvements in hypertension control for the participants in that program. And again, that is a coaching program. It's also a healthcare navigation program where thousands of members of the program actually got support in making sure they didn't have to pay for the healthcare that they needed to control their hypertension or other chronic diseases.
So the heart age calculator tool is great for providing an estimate of your heart age based on risk factors, but does not include an option for race or ethnicity. Based on the known disparities in risk factors for Black and brown women, why is race not accounted for in the calculator?
Thank you for the question. This is a very hotly debated topic right now in clinical care and in medicine, is when should race and ethnicity be used in calculators and in algorithms to help providers to diagnose and treat illness. It's hotly debated because on the one hand, race can be a marker for risk of having worse outcomes. On the other hand, race is not a biological category at all. And so because race is a social categorization, not a biological one, it can be blurry to decide when to include race and when not to. Sometimes if you include race in a calculator, it can mean that it kind of normalizes a racial inequity in a particular disease, instead of really highlighting that the only reason that that disease is more common in, say, Black women is actually because of social factors, including racism, not because of Black race itself. And so we have to play this very difficult balance between when to include race and when not to. In general, our guidance and our belief is that race should be included only when it's going to help us reduce racial inequities. If race is included in a calculator or an algorithm in a way that normalizes or even worsens racial inequities, then it's not useful. If it's included in a way that's going to allow us to target resources to communities that have unfair outcomes, then it is a helpful tool to include. So for the heart age calculator, I would say we have more conversation to be had about whether or not it's a useful tool in reducing racial inequities in heart disease.
So, and the last thing I want to raise for right now is, so there are, and this is just something to think about in terms of Healthy NYC. I haven't had a chance to talk to the commissioner about this yet, but there is a new phenomenon of injectables for medications. I take one for cholesterol, for very high cholesterol. We need to make that available to the masses, and just like, you know, this administration was very forward-thinking in the Rest in Peace debt and putting money towards that, if there's a way that we can do this to cut down on cardiovascular disease and other things for women, there's actually something in the pipeline, because I do a lot of reading on this, is for high blood pressure, and it's now in the second phase of the clinical trial. There's going to be an injectable where you get every 6 months an injection that will totally control your high blood pressure. So these are things we need to really take a look at that can help a lot of people and be cost effective. So I just wanted to put that out there. And with that, I'm going to, Councilmember Menon has some questions for you. Thank you.
Oh, thank you so much. I really want to thank the chairs for this very important hearing. So I have a couple questions related to cancer. And I just want to say at the outset, I think it is just so disconcerting and unconscionable nationwide that we're not seeing the cancer rates by and large falling. And it makes me think, like, back in I mean, if you look at back in 1972, President Nixon declared a war on cancer, and by and large, that war is like we are in an even worse situation in so many different areas. And the new research that's come out for women under 50 is really, really alarming. So I have two questions related to that. First, the mammography vans, which are so great and so important, and I fully support, and I'm doing one in my district. My question is, when a mass is for a woman who's being screened for a mammogram and you find a mass, what then happens, and how is the city helping these women navigate the complex process of breast cancer?
Yes, thank you for that question, Councilmember Menon. It's a major area of concern for us as well. One of the things that we worry a lot about is the time from diagnosis of an abnormal mammogram to a final diagnosis of what the issue might be on that mammogram, and then into actual treatment if it turns out that the abnormality on the mammogram is breast cancer or some other cancer. This is one of the most important areas of intervention in cancer care and early treatment, and so we agree with that concern. The current work that we do with the mobile mammography van actually does have navigators as a part of the program. And so what those navigators do is when someone who has their mammogram on the mobile van has an abnormal mammogram, the navigator helps to reach out to them to make sure they understand the abnormality and helps them to, as quickly as possible, get into a follow-up visit to figure out if they need further diagnostic testing, whether that's a biopsy or an ultrasound or something else, and then helps them to get into treatment. So that is part of the mobile mammography program. I am not saying that that happens for every mobile mammogram van, but for the one that we partner with at the health department.
Just two other quick questions.
Yes.
Do we follow the woman who has abnormal mass? What is the communication that happens? Are we following that woman? Are we in constant contact with them to make sure they are accessing treatment? And then I have one other quick question after.
That is exactly the role of the navigator, but we can follow up and share more data with you on how, what that looks like, what the calls, the text messages, and what the specific follow-up communications are.
And the last question I have is, as you know, there's incredible research on genetic mutations, not just on BRCA1 and 2, but CHEK2 and many, many others. And as someone who carries one of these genetic mutations, it has changed my life in terms of knowing that I need to have more frequent screenings, not only on breast cancer, colon cancer, all of these different areas. Some health insurance companies are now paying for this because it lowers overall the health care costs across the board. So what is the City of New York doing? Are we testing, and the hearing is obviously focused on women, are we testing women for these genetic mutations? And if so, how are we doing that? And if not, why not?
That's a great question. I would tell you that right now there is not. I don't think that we have specific guidance actually on that. It is something that we can follow up with you about, so that we can make sure that at least what information we're sharing with patients is up to date. As far as I'm aware, I don't actually have all the information about which insurers pay for the genetic screening, but that's something that we can follow up about.
Great, thank you very much.
Councilmember Gutierrez.
That was fast. Thank you so much. Thank you, Chairs Lewis and Chair Schulman, for this hearing, and thank you, Doctor, for your testimony today. My questions will be fast. I just wanted to quickly also uplift Dr. Manette. I think she's been incredible, and I was able to visit the Family Wellness Suite in Brownsville and just really learn about how women are informing health decisions in our communities and how transformative that is. My question is, I love hearing your commitment to doulas and midwives. I think it's absolutely important. Something that we're facing citywide is just this constant tossing of, we appreciate you midwives, your work is paramount, but either we're not going to renew your contracts, and I know you can't speak a whole lot to it, but I just think it's really important to elevate because it's kind of contradictory to say we care about women and we care about keeping Black women alive particularly, and so we're going to create pathways to have more opportunities for midwives and doulas, and then we see citywide either a hospital is shutting, the unit is shuttering, their contracts are not being renewed, and so I would just love a sense from you all, the bigger picture with like, if we are saying that this is a solution to keeping women alive, to keeping birthing people alive, then what do we need to do to ensure that we mean it? The council, as you know, was very instrumental in passing a number of these initiatives. And again, really proud of the work that's happening in Brownsville. I loved hearing that C-sections were down. Like, it was all very positive, and when you invest, good things happen. But if we care about midwives and we care about doulas and we care about women, then why can't we just show up for them when it's time to pay them?
Thank you.
That's it.
Thank you, Councilmember Gutierrez. I also share your admiration for Dr. Zahira McNatt and the work that the team is doing in Brooklyn. And we are also really encouraged by those outcomes. A couple of things I would say in response, and completely agree with your concern. The first is that we do collaborate closely with the New York State Health Department. And that's important because they participate a lot in setting rates of reimbursement for various services. We're happy that finally Medicaid is actually reimbursing doula care starting this year at a higher rate than it had been in upstate for New York City-based doulas, which is very exciting. So that collaboration continues because the state health department is so influential in this space. We are very excited about our midwifery initiative and would love to follow up with you and set up some time to tell you more about the progress to date in the initiative. Helena Grant, who's a midwife, started working with us last year.
She was one of my midwives?
Yes. And so
it's deep for me.
So we share your concern. And although we do not directly employ midwives who work in hospitals across the city, we do regularly have conversations with hospitals across the city who are involved in birth equity work about ways in which they can improve health outcomes for birthing women and birthing people, and midwifery is always a part of that conversation. So we'd be happy to follow up with more on our midwifery initiative.
Councilmember De La Rosa.
Thank you so much. I just want to say your testimony has been great, and thank you for engaging us. This is such an important topic. I wanted to ask about life expectancy, and I don't know if you've touched on this because I came a little late. I was in the transportation hearing, but we've heard a lot, and our chair has really been focusing a lot about increasing life expectancy for New Yorkers, and I'm wondering if there's anything that you've looked at in terms of women of color in that realm.
Thank you so much for that question. Yes, this is a huge area of concern for us. Our Healthy NYC initiative and the goals around Healthy NYC were really all around the concerning decrease in life expectancy that happened as a result of the pandemic, particularly in 2020, but really every year since. For the whole entire city, the life expectancy went down to 78 years in 2020. As of 2021, life expectancy on average across the city has increased to 80.7 years. We just released that 2021 data last week. We are able to look specifically at life expectancy for women. Women's life expectancy has always been a little bit higher than men's for a number of reasons. That is still the case, but overall life expectancy is still down from where it was pre-pandemic. So the goal within Healthy NYC is to reach a life expectancy of 83 years by 2030, and we'd be happy to follow up with you on some numbers specifically for where women are and where women of color are. I will also say that even before the pandemic, Black people, men and women together, on average had the lowest life expectancy of all New Yorkers at 74 years, and that was pre-pandemic. And to this day, we still have significant inequities in life expectancy by race and ethnicity across the city. And can I follow up on just one other thing that came, sorry.
No, that's it. Thank you so much.
Okay, thank you. I just wanted to follow up on a couple of prior questions that were raised. I wanted to add that Take the Pressure Off, our blood pressure initiative, has provided over 1,000 blood pressure monitors to sites across the city for patients with hypertension who have difficulty getting blood pressure cuffs. I also wanted to follow up on Chair Louis, your question about Local Law 87 that was passed in 2022 regarding polycystic ovarian syndrome and endometriosis. As per the local law, we submitted our report to Council last year and will submit a new report next month. Information about polycystic ovarian syndrome and endometriosis are also found on our website, PCOS and Endometriosis NYC Health. Yes, those were the two things I wanted to follow up on from other questions.
Councilmember Marmorato?
Hi, thank you. Thank you very much, Dr. Morse, for the testimony. So I just want to let you know that I have a 24-year career in breast imaging, and we are in a breast imaging crisis here in the city and in the state. When your tagline is early detection is the key to survival, there is no reason why women of the city should have to wait months for a screening mammography appointment. Is there any initiative that you have set up where we can increase the amount of facilities or increase how these practices operate, whether they can increase their appointment time or amount of appointments? Do you have anything set up in place for that?
Thank you so much for that question, Council Member, and I was not aware of that expertise, but that's wonderful. We do not currently have any initiatives to increase the capacity and infrastructure around mammography in the city. However, we do see the mobile mammography van as kind of a gap filler, and one way to try to bring the services to where the people are, but currently we don't have any initiatives to expand that capacity. I will also say that the more we can reduce any cost sharing or any co-pays or fees that people have to potentially pay related to preventive care is very helpful. And I would also say that part of our goal around mammography access is still reducing the rate of uninsurance for New Yorkers to zero. Nobody should be without health insurance, and that would also help with access to mammography.
Okay. I also have an event set up in my community with the mobile vans. I'm going to try to do a couple of them throughout the year because I understand the importance of women's imaging. Now, to build on Councilmember Menin's question as far as the follow-up with these mobile vans, is there anything kind of set up in place? I've worked with clinical patients, and I know how hard it is to follow up with them. And I just really wanted to know, with these nurse navigators, is there any way you can set up harder guidelines or some type of database to kind of really stay in contact with these patients?
Thank you for that question. That's something we can definitely explore, and we can follow up with you about more information on what the navigators' activities look like and how they track the information for the patients who get the mobile mammograms.
Okay, thank you.
Mm-hmm. Thanks.
Yeah, I have a question and yes, and a comment. The question is, often LGBTQ people avoid healthcare facilities due to historical discrimination and violence faced in these spaces, but when they do try to access these spaces, they're often once again receiving inadequate care because once their sexual orientation or gender identity are revealed, physicians solely focus on this aspect and relate their symptoms back to sexuality and gender. What is DOHMH doing to push back against this mentality to ensure the LGBTQ individuals are obtaining adequate care?
Thank you so much for the question, and this is an area of serious priority for us at the Health Department because of our health equity work. One thing that I can say is that we spent several years actually updating our internal guidance on data collection for people who are LGBTQIA, and that's because there isn't actually a whole lot of great guidance out there on what local health departments should be doing for data collection to make sure that we know what the sexual identity and gender identity of New Yorkers is. So we have spent quite a bit of time through our data for equity work and guidance at the health department to make sure we're clearer and have clearer guidance in both how we collect that information and how we report it out. So the data part is core to what we do. We also do service delivery work when it comes to LGBTQI populations through our sexual health clinics. Our sexual health clinics are a really amazing resource for all New Yorkers, but particularly for people who identify as LGBTQIA, and specifically also for people who are concerned about their sexual health and want to have a walk-in care option. So our sexual health clinics are either no cost or low cost for all New Yorkers. They're open door policy. They have walk-in appointments or just walk-in care, and address all kinds of different sexual health and reproductive health needs. And so that is another space where we really prioritize inclusiveness and really, care that is competent and thoughtful and accessible for people who are LGBTQ identifying.
Didn't some of the sexual health clinics close because of budget cuts, or?
We still have several sexual health clinics that are open, but yes, some of the services have shifted.
So I want to just go back for a second to Councilmember Menon's comments. The genetic testing, that's the same as biomarker, is that correct?
Not always.
Not always, all right. The reason I brought it up is because there was a bill that was passed by both houses of the legislature last year, was on the governor's desk. Nothing happened with it to make insurance companies actually pay for biomarker testing, so which they don't cover now. So I'm going to go back and look at that, but maybe that's something you guys can look at maybe there's possibilities of doing legislation or resolutions or whatever that we can help with in terms of that and genetic testing to make sure that insurance companies actually pay for that.
I'm not aware of that bill, but we can look more into it.
I'll get you more information. I don't have it in front of me now. Thank you.
Mm-hmm.
All right, 2 quick questions. You mentioned earlier the Office of School Health and the focus on children. So I wanted to ask, how is your agency supporting mothers with children with this particular office? How do you support children who have asthma and their mothers with getting access to services?
That's a great question. Our Office of School Health, we have an asthma case management program that works in certain schools across New York City. And what happens with that program is that if, as a child is enrolling in school, if it's noted that they have a diagnosis of asthma, the asthma case manager will contact the parent and engage with the child as well to make sure that there is an asthma management plan on file within the Office of School Health or with the school nurse at the school, and will also help to coordinate care, counseling, information sharing, all the kinds of things that would help to reduce the chances of an asthma exacerbation for the child. And so that asthma case manager also certainly engages with the parent and make sure that the parent has access to the resources that they need. But that is really more focused on asthma. The school health program is focused more on asthma than other services.
And this is citywide?
We could follow up with you for the specific schools where we have that program, but yes, it is citywide.
So is the city also taking steps to improve air quality in areas in the city that have heightened rates of CLRD?
That is a great question. Our colleagues at Environmental Health within the city, they are the part of the city government that's responsible for monitoring air quality and reporting it out. And so that is a huge priority for us. In fact, I know that there is a lot of work that we're currently doing around congestion pricing and air quality related to that. We could certainly follow up with you on some of our efforts around air quality.
It would be good to know how you both are partnering together to provide that. And last question, does your agency collaborate with the Department for the Aging to ensure that older adults, or particularly older women, have access to up-to-date information on Alzheimer's disease and risks?
Yes, I should have mentioned that earlier. Thank you for the question. We work very closely with the Department of Aging. In fact, they have several programs focused on Alzheimer's and dementia and many other areas. So we do work quite closely with them, and they have been a partner to us on the initiative I mentioned called BOLD. So they are partners with us on the BOLD initiative.
Do any other members have any questions? All right, I'll hand it back over to our council.
Thank you, Chair, and thank you very much, members of the administration. We will now hear testimony from the public. I'd like to remind everyone that I will call up individuals in panels, and all testimony will be limited to 2 minutes. I would like to note that written testimony, which will be reviewed in full by committee staff, may be submitted to the record up to 72 hours after the close of this hearing by emailing it to testimony@council.nyc.gov. Also, if you are looking to testify in person today and are in the audience, please make sure to fill out a witness slip with the sergeant at arms in the back of the room. For our first panel, I will call up Doria Kyra Bate, Chris Norwood, and Christopher Leon Johnson. So we have 3 people, these are only 3 people in person, and then we have about 5 on. Okay, yeah, I think with that many people, it shouldn't be too long, but I may have just jinxed it, so we'll see. Yeah, that's the 3 people.
Nice glasses. I'm actually staying to hear it. Nice glasses. Thank you for sharing that. It's really important.
Okay, okay. You may begin when ready.
Thank you. Good morning, and thank you for convening this critical panel addressing disparities in women's health. My name is Doria Kyra Bate, and I am an attorney at Legal Momentum, the Women's Legal Defense and Education Fund. As the nation's first and longest-serving legal advocacy organization for women, one of Legal Momentum's focus areas is to protect women and their families from being penalized for their pregnancies and pregnancy outcomes by combating discrimination in the systems that serve them. Through our national helpline, our impact litigation, and our policy advocacy, we have seen firsthand how non-consensual drug testing in healthcare settings negatively impact pregnant patients and their families, particularly low-income families and families of color. In performing non-consensual drug tests on pregnant patients, a practice which is rightfully not used on all patients, healthcare providers make a treatment distinction based on sex and pregnancy, a clear violation of New York's discrimination laws. The consequences of this overtly discriminatory practice has a disproportionate impact on women. Those patients who have a positive toxicology result after non-consensual drug testing are most often not provided any medical counseling or treatment. Rather, they are exclusively reported to Child Protective Services. Drug testing pregnant patients, not for any medical necessity, but for solely punitive purposes, amounts to an unlawful search and seizure and undermines the health and well-being of the mother and child. Numerous studies and investigative reports have found that Black parents are more likely to be screened, tested, and reported for illicit drugs than their white counterparts, even though race is not associated with a positive result. And despite similar usage rates across racial groups, we have found that these practices are often more prevalent in hospitals serving lower-income Black and brown communities. Because drug testing criteria are not standardized across hospitals, healthcare providers often have discretion in determining whether or not to screen a pregnant patient, making way for implicit bias and discriminatory practices. From our experience, these practices have in fact disproportionately targeted women of color. May I continue with the recommendations? Or?
All right, you have 1 minute.
Okay. It is critical that patients are fully informed of the consequences of perinatal and newborn drug testing, as well as the medical reasons for testing, and that they will not receive appropriate medical care as a result. We recommend healthcare providers to establish a clear written policy that directs relevant staff to refrain from drug testing pregnant patients absent informed consent and medical necessity. In providing informed consent, staff must advise patients of all known consequences that may stem from drug testing. In addition, we advise healthcare providers to maintain the confidentiality of any drug testing and to refrain from reporting pregnant patients to Child Protective Services based on a positive toxicology test alone and absence independent indicia of child abuse and maltreatment.
All right, thank you.
Thank you.
You may begin.
should know, but it's red. Okay. I am Chris Norwood, Executive Director of Health People. I will be focusing on two related disparities which are driving such poor health for women, especially Black women. And we are in an unprecedented situation where government at every level, and this tragically includes the New York City Council, are letting women massively suffer disability and death, which is often preventable. These disparities are diabetes and Alzheimer's. I think Healthy NYC and the accompanying legislation are important steps, but it is also telling that Healthy NYC does not mention the fastest growing cause of death for women, which is Alzheimer's disease. Leaping from the 21st cause of death in 2000, it is now specifically the 6th leading cause of death for women. At the same time, diabetes rose from the 8th leading cause of premature death overall to now being the 4th leading cause of premature death for women. But I caution against using premature death rates as a sole primary measure of what people are doing. Nothing has the overall devastation of diabetes, which has struck 1 million New Yorkers. It fuels other diseases that deeply concern you across the board, including heart disease, high blood pressure, several types of cancer, poor birth outcomes, and it is a major, major trigger of Alzheimer's. 2/3 of those with Alzheimer's are women. We do know, however, that Alzheimer's is significantly preventable, and a major route for prevention is controlling diabetes. People diagnosed with diabetes before age 60 have an 80% increase in Alzheimer's risk, but even so, helping them reduce blood sugar levels from poor control to moderate control slashes Alzheimer's risk by 30%, and bringing blood sugar to good control slashes Alzheimer's risk by 60%. This has never been incorporated into our priorities in the city at all. Black women experience twofold the Alzheimer's rate of white women, and this means that in New York State, the same populations and the same communities that were ravaged by COVID-19 are now being ravaged by Alzheimer's.
If you could finish your remarks.
I will in 1 minute, I promise. We have begged and begged the City Council and Health Department to support community diabetes, self-management, education. I was happy today, for the first time, we did hear some beginnings of focus on that for the first time, with 1 million people affected. So we have a health department that has decreed racism a public health crisis. We have a city council that is majority women, but we have a hideous legacy, which we must focus on. There is no other term except hideous, of neglect of the two most predominant disparities that most injure women and Black women
Thank
most.
you.
Thank you
So much. You may begin.
What's up, everybody? My name is Christopher Leon Johnson. This is my first time at a women's committee. It's rare for me, but when I saw that postcard over there to your right or your left on the screen, I was so disgusted of what I saw. We see over here that majority of the disparities happens more in the impoverished district, and the highlighted area shows, I believe that's my district, that's my council district, a little part of my council district, and a little part of Hudson's district. Now, the real reason this is happening is because they are allowing bad foods in these districts, in those impoverished districts. All the impoverished districts have all the bad foods. When you eat the bad foods, you have high chance of having these diseases like diabetes and premature death and all the other diseases that happen to your body system is will be way higher than all the other non-areas that are shaded a little lighter. And we all know why is that, because they have better food. Trader Joe's, Whole Foods, Reserves, while all the impoverished areas have NSA and Associated and C-Town and Shop and Stop and Target, which is like, every time we go to Target, is like gas food, and Walmart, which is like gas food too. So that's the reason it's happening, because the foods are horrible. You have, in these districts, in these impoverished districts, you have to push for more healthier foods and more execution of the funds that the government, like the city council and the state assembly, state senate, and the federal government give to these areas to implement the services to make sure this doesn't happen. We don't know what's is that majority of this money is going to these executive directors' pockets, basically in those impoverished districts, and all these, and I'm not saying all you guys here, but none of these council members and none of these elected officials, all they care about is being reelected. So they allowed this to happen with these nonprofits that so-called fighting for the people equity of health in the impoverished districts. All they care about is lining their pockets. And one more thing is we need to stop funding these cure violence organizations, because the reason I'm saying is because a number of these hospitals like Jacoby and Lincoln Hospital and King County and downstate, they're getting a lot of money from the government for these cure violence initiatives. We have to defund that and drive more into pregnancy, promoting pregnancies.
Thank you.
And maternal health and cardiovascular health in these communities. So that's all I gotta say. Thank you so much.
Thank you for your testimony.
Thank you.
He is going to the heart of the matter. And something the City Council and Health Department can do together is have New York have a waiver that really counts for health. And that is a waiver from having to distribute sugary soda under the so-called Supplemental Nutrition Program. 10% of that money goes to sugary soda. And you can ask the federal government for a waiver. For New York City, you could ask New York State to join in that.
If you could join us in that effort, we'll appreciate it. I want to thank this
sure
panel
will.
for coming and testifying. Thank you for your time.
Thank you.
Before you go, I want to you, Mr. Johnson, for testifying. I want to say a couple things. One is that's why we have Go NYC in a lot of places, in a lot of different areas, and so we're trying to grow that as well. So
Yeah, I'm gonna say I know
no,
you're
but I appreciate what you said.
I know you're
because
growing
we
it.
need better.
Yeah, I appreciate it. I know you're growing it, but defund these cure violence organizations and drop it to that. That's all I gotta say.
Understood.
Thank you.
Understood. Thank you.
Thank you.
And to Ms. Norwood, we're like I said, the City Council, we're trying to move in a lot of different directions. We passed the first comprehensive diabetes bill last year. The Department of Health has a year, that's why I brought it up today, has a year to put together the plan and all the different elements that go with that, and that's not due until April. So, and we're working closely with them, and once that's out, we're gonna make sure to include you as part of that as well. So thank you very much.
You're welcome. I don't know if the actual working report has been distributed to the council, has it?
It's due in April.
No, the working report has already been released. That's the working report, which is the basis for.
So
and I don't think that has been
we'll follow up, but
distributed
it's
to
going to
the
be, it's supposed to be officially out, and I've been working with them, with the Department of Health on looking at various aspects of it. So thank you.
council. All right, thank you.
Thank you. I'm going to hand it over to the committee council.
Thank you. If there's no one else in the room that is signed up to testify or would like to testify, that would include the in-person portion of our public testimony. We will now move to remote testimony. If you are testifying remotely, once your name is called, a member of our staff will unmute you, and you may begin once the sergeant at arms sets the clock and cues you. For the people, first four people on Zoom that will testify will be Elise Benusa, followed by Lauren Schuster, followed by Rosemary Martinez, and concluding with Yesenia Mata. Elise Benusa, you may begin once you are unmuted and the sergeant cues you.
Time starts now.
Good morning, everyone. I'm trying to show my video, but it won't let me, so I can just go ahead. Good morning. My name is Elise Benusa. I am the Government Relations Manager at Planned Parenthood of Greater New York. Thank you to the committee chairs, Councilmember Lewis and Schulman, for holding this important hearing addressing disparities in women's health. PBGNY has been a leading provider of sexual and reproductive health services in New York City for more than 100 years, conducting over 132,000 patient visits per year. Since the overturning of Roe v. Wade in 2022, 26 states have imposed severe abortion restrictions. We have listened as patients described their journeys traveling across state lines to reach New York. In response to the SCOTUS decision, PBGNY has hired patient navigators to help individuals forced to travel to and living in New York City secure the care they need from a trusted provider. PBGNY applauds the New York City Council for their legislative leadership to ensure every New Yorker and folks traveling to our state for reproductive health services receives the quality care they deserve without fear or financial burden. This council has shored up protections for abortion providers and patients in our city. We must continue to be the beacon of hope we aspire to be. We must continue to fund abortion access and the New York City Abortion Access Hub through the city's budget. Our recommendation to the council is to streamline the funding acquiring process to ensure vital organizations like New York Abortion Access Fund and the Bridget Alliance are receiving the resources they need to provide life-saving support to patients in New York and across the country. In the months since the overturning of Roe v. Wade, our PBGNY health centers have experienced an increase in anti-abortion protests. Our Manhattan Health Center has experienced an exponential increase in protesters, which is a combination of members of the local church, pro-abortion clinic defenders, and the NYPD officers, including members of the Strategic Response Group. On the first Saturday of each month, New York City permits anti-abortion protesters to march from their church to our health center with police escorts. Their procession concludes outside of PBGNY's Manhattan Health Center, where they engage in a ritual that is intended to shame patients who are entering and leaving the health center for vital reproductive health services.
Time expired.
Can I just finish in 30 seconds?
Yeah, just wrap it up.
30 seconds.
This attracts large crowds on either side of the issue, leading to a disruption in patient care. PBGNY staff and patients and volunteers are regularly face physical and verbal harassment by the anti-abortion protesters. PBGNY has been in regular communications with legislators, community partners, and the NYPD to uplift the concerns we have with patients. Our recommendation to the council is to explore solutions to address this issue, and one pathway we recommend is for the council to explore the current event parade issuing process that allows the church group to march to the health center, often with NYPD escorts. Resolving this issue will be a critical step in New York being a true reproductive rights access state and will ensure that New York City is living up to its values.
Thank you so much.
Thank you. Lauren Schuster, you may begin once you are unmuted and the sergeant cues you.
Starting time.
Hi, everybody. I'm Lauren Schuster, the Vice President of Government Affairs at Urban Resource Institute. Thank you so much for the opportunity to present testimony today. URI is the largest provider of domestic violence temporary housing for survivors and their families in the country. And we are a leading provider of temporary housing for families experiencing homelessness. Domestic violence poses a serious and growing threat to public health and safety. Though DV does not discriminate here in New York and across the country, women continue to be disproportionately impacted by DV. Between 20 all victims of domestic violence homicides in New York City, while accounting for only little more than half of the overall population. And the rates of domestic violence homicides and felony assaults have increased. Between the 1 year period of 2021 to 2022, DV homicides increased citywide by 29%, with a 225% increase in Brooklyn and a 57% increase in the Bronx. Just this past weekend in the Bronx, Saidia Bania, a 40-year-old Black woman, was shot and killed by her former partner, an individual who allegedly was stalking her and who Saida's family reported had been abusing her throughout their relationship. The individual also shot Saida's young nephews, aged 16 and 9. A domestic violence homicide like this one has long-lasting impacts that ripple out throughout generations of families and communities. These children, their families, and the families of everyone involved, including friends, neighbors, and members of the community, will be grappling with the physical, emotional, and psychological impact of this tragic situation for years to come. And Black women like Saida continue to be disproportionately impacted by domestic violence. The same is true for Hispanic women. Like many other persistent public health problems, DV impacts marginalized communities in far more significant ways. And as like other growing health problems, the city has a responsibility to mobilize resources to slow the rates of domestic violence.
Time expired.
If you could wrap it up, thank you.
I will. We can stop domestic violence by investing in community-led solutions that center equity and the voices of survivors and impacted communities. We must invest in violence prevention that is designed to address family violence, like youth violence prevention and healthy relationship education, trauma-informed accountability work for people who have caused harm, and workforce development and economic empowerment services for survivors and their family. I look forward to continuing to partner with the council on this important work. Thank you again
Thank
for the
you.
opportunity to testify today.
Thank you.
Thank you so much. Rosemary Martinez, you will be testifying next, and I will note that you will be testifying on behalf of yourself, as well as then followed by reading a testimony for Tatiana Behar. You may begin once you are muted and the sergeant cues you.
Starting time.
Thank you. Good morning, Women's Committee Chair Farah Lewis and Health Committee Chair Lynn Schulman for the opportunity to speak today. My name is Rosemary Martinez. I'm the domestic worker organizer with Carroll Gardens Association, one of the organizations that is part of the New York City Coalition for Domestic Work. Our coalition is a movement of domestic workers, domestic employers, parents, family caregivers, older adults, and people with disability working together to transform New York City's care economy into one that is equitable and sustainable for all. The coalition leading organization are the National Domestic Workers Alliance, New York, ADICAR, Carroll Gardens Association, La Colmena, and Hen in Hen, the Domestic Worker Employers Network. As other our coalition members testifying today, I'm here to request your support for the Domestic Worker and Employer Empowerment Initiative for fiscal year 2025, which will provide 700,000 in much needed funding for our outreach, education, and enforcement support to over 8,000 domestic workers and employers this year, and ensure domestic workers can work in healthy and safe working conditions, promoting dignity, respect, and fairness in domestic work relationships, ultimately leading to better outcomes for both workers and employers. We are working closely with our industry in the many areas of New York City, and we are listening in my capacity as domestic worker organizer and as a domestic worker in NYC. Benefits like paid time off, healthcare, most of them not having medical coverage and retirement, are still unavailable to domestic workers who are also frequently underpaid. Racial and gender inequity in our communities made worse by the fact that women and people of color make up the great majority of domestic workers, despite the fact that we have welcomed numerous significant legislative victories since 2010, such as the NYC Paid Safe
Time
and Sick
expired.
Leave, the New York Domestic Worker Bill of Rights. We look forward to working with you to build a city where domestic work is valued and dignified. Thank you so much.
Thank you.
Thank you. And just checking, did you provide the testimony for Tatiana Behar as well? Rosemary?
They have their testimony.
Okay, perfect. Thank you so much. And then the last name I have is Yesenia Mata. You can begin once you're unmuted and the sergeant cues you.
Starting time.
Thank you, Chairwoman Lewis and council members on the committee for allowing La Colmena to speak today. My name is Yesenia Mata, and I am the Executive Director of La Colmena, an immigrant and worker rights organization based on Staten Island. Through our work, we have been able to be in the forefront of supporting new arrivals, which includes women, and teaching them about the rights at work, and as well as you know, organizing on Staten Island for immigrant rights is not easy, as it is known to be one of the most hostile boroughs for immigrants. But despite the threats that our center gets from those that are anti-immigrant, we stay focused on our mission, which is to empower the immigrant worker through education, culture, organizing, economic development. We are proud to say that through our work, we have been able to empower women, immigrant women, that every day wake up to head to work to provide for their families. And whether they have been here a long time or recently, we remind them that they have rights. We remind them that they have rights, such as through the Domestic Worker Bill of Rights, paid safe, and sick leave, and keep reminding them that they should not be exposed to harmful chemicals at work when cleaning. This issue is important to me on a personal level as a daughter of an amazing immigrant woman who came here to work as a domestic worker to pursue the American dream. This is why we are proud to say that we recently became members of the Domestic Worker Initiative, which includes the National Domestic Workers Alliance, Attica Carroll Gardens Association, and Hand in Hand, which together we support over 8,000 domestic workers. We hope that this year, just as we continue fighting for immigrant domestic workers for their rights, which includes their health, that we can count on your support on fighting for this initiative that supports many immigrant domestic workers and reminds them about their rights. So I thank you for your time and leadership, Chairwoman. The health of immigrant women is a fight for women rights. Thank you.
Thank you.
Thank you.
Thank you. I will note that we had registrations from Jesse McLaughlin, Alex Hayden, Sabrina Laseg, and Black Women's Blueprint that we don't believe are online or in the room. If there's anyone present in the room or on Zoom that hasn't had the opportunity to testify, please raise your hand now. Seeing no one else, I would like to note that written testimony, which will be reviewed in full by committee staff, may be submitted to the record up to 72 hours after the close of this hearing by emailing it to testimony@council.nyc.gov. Chairs, we have concluded public testimony for this hearing.
This hearing is now closed. Sorry, sorry? You'll send it on email. All right, thank you.
Sorry about that.
This hearing is now closed.